Welcome to the Critical Care Obstetrics podcast. I'm Dr. Stephanie Martin, maternal-fetal medicine specialist and medical director at Clinical Concepts in Obstetrics, and I'm here with my amazing partner, Suzanne McMurtry Baird, the nursing director at Clinical Concepts in OB.
Hey guys.
Yeah, I've been looking forward to and dreading this recording. I've told you because today we're going to be talking about the Pitt.
Yeah.
And a particular episode in the Pitt.
Yeah. I mean, who would have thought we were going to be talking about a pregnant patient in an emergency room?
Well, they kind of teed it up for us. And it was really timely because, we just had that conversation with Jen Hamilton about the ED and labor and delivery. And, this is something we actively teach on and talk about all the time and deal with teams that are really struggling with how to navigate care of the OB patient in the ED. I mean, it's not easy.
Right. And you've got to have a plan. You've got to have a process on how you deal with this. And, I'm just excited to talk about it. And I'm really excited that you watched it because I've been trying to get you to watch the show because I love it. I love the character development in the show. I love fast-paced, dramas like that. But I think they get into a lot of really right-on, issues that are current for healthcare providers and how they're dealing with some of the systems issues in the hospital and systems issues with patient care and then just with each other and with relationships. And so I've been trying to get you to watch it, but you wouldn't watch it.
I've always had this thing where if everybody's into it, I'm not into it. I've just that's just the stubborn, annoying part of me.
Rebel.
I am. I just never get on the train that everybody's getting on. It's just a weird thing of me. But more than that, it just seems I've always had difficulty watching medical shows except Scrubs. I felt Scrubs was like one of the most accurate medical shows out there. And it was funny and it was compassionate and touching. I just thought it was just dead on with my experience of medicine and my years of training and stuff. But most of the others just make me angry because they get it so wrong and I can't get past the fact that it's so wrong.
I had to enjoy watching George Clooney, I'm sorry. What was it? Dr. McDreamy and Dr. McSteamy.
Well, that was Grey's Anatomy.
Grey's Anatomy.
Grey's Anatomy.
That's right. Yeah.
Yeah. I liked watching Grey's Anatomy in the first few years of it, and then it just got really drawn out. I'll tell you a funny story. When I was a resident, and remind you, I was a resident in the 90s, okay? And so that was when ER was on, and I didn't have any time to watch TV, and there was no streaming back then, and
Right.
I couldn't afford VCRs and recordings, and I don't even know if TiVo was a thing, but it was hard if you weren't off and in front of the television the night that it came on, you weren't going to watch it. And so
Right.
I didn't get into episodic TV much because, residency
Yeah.
with no work hour restrictions. So I knew of the show, obviously, but I didn't watch it religiously. One year I was a second year resident and I went into this patient's room and, as a resident, you're constantly having to justify your existence and people had very strong opinions about whether they would allow you to participate in their care or not, which is totally fine. But as a resident, it's exhausting when it happens all day, every day, right? And I remember walking into this patient's room and I introduced myself. I tell them I'm the resident and I'm going to be involved. And the patient her boyfriend or whoever it was were like, wait a minute, you're a resident? And I was like, yes, I'm a second year resident. Oh, they're like, wait, you're a resident, like on ER? And I was like, I kind of looked at her and her boyfriend was like, that's amazing. You need to listen to everything she says because she's a resident like on ER. And I was like, yes, they're gonna.
The one time, someone said, don't get out of my room. You're a resident. You're a learner.
Like, yes, listen to everything I say. No.
Well, I do. I enjoy the show, but I'm glad you watched this episode anyway. So
I might go back and watch it. I'll be honest, I was worried it was going to be just too traumatic because people have talked about how realistic it is and all the, and I've been burned out in medicine several times and I've worked in high stakes, high stress, high drama environments for most of my career. And I was just worried it was just gonna be trauma, just trauma. Why would I wanna watch trauma, my trauma, you know?
Yeah.
So, but I enjoyed the part that didn't involve the OB patient.
See, and I love high risk, high drama, that kind of action,
Yeah.
even though those shifts are so hard on you
Mm.
physically and mentally. Um, I thrive on that. So if I didn't work OB, I'd want to work ED.
Almost did an ED residency, like, I didn't interview or anything, but in medical school, I was trying to decide between OB and ED because I love the adrenaline. I love that kind of, you know, environment and care environment, but
Yeah.
I came to realize that really, a huge majority of the ED is dealing with things that can be served in or need to be served in other environments, in a
Yeah.
primary care environment, in a
Yes.
psychiatric environment, in whatever, and it wasn't all the trauma and life-threatening, which it can't be and shouldn't be 24/7, but I just was like, "That's not a fit," because I can do that in an OB world, but at least I theoretically get the benefit of a patient relationship.
Yeah.
And in the ED, if you have a patient relationship, it's probably not a good thing for the patient or for you because why are they getting
Yeah.
so much care in the ED that you have a relationship with them?
Exactly. Or why are you here again? Because they don't have healthcare any other
Right.
way.
Which is frustrating and challenging for the patient and the providers because
Right.
everybody knows it's not the right place.
Right. Right. But I enjoy that pace. I just think as having been an L&D charge nurse for so long, I would want to move the patient along quicker.
Yeah.
And that doesn't happen in an emergency room, and I don't understand that. Because in L&D, we move them along from place to place, or they're in, and if they're ruled out in labor or whatever, they're out. And, once you get your criteria met, they're done, they're out.
Mm.
But that just doesn't happen as quickly in the ED, and I don't understand that. So maybe some of our listeners will, you know, give me some hints as to why that doesn't happen, because as a patient, it's horrible. As a
Mm.
healthcare provider and a previous L&D nurse, I would be wanting to move them out,
Mm.
and why
Yeah.
that can't happen. So anyway, well, let's talk about the episode.
So this is the season finale of season 2, and,
Episode 15.
okay, episode 15, it's the season finale, and, um, the it came to my attention because or I saw an article or something about it talking about free birth and a wild pregnancy, and I went into the episode thinking it was going to be about, like, focusing primarily on wild pregnancy and free birthing, which we should probably talk about what that is,
Yeah.
so
So this patient had had no prenatal care.
mhm, by
Um,
choice.
by choice, yes.
Yes.
By choice, did not want any medical interventions. And so I believe that's kind of the start of the um, wild pregnancy, free birthing movement is no medical care.
Yeah, and I think the idea is, and the patient kind of expresses this a little bit, women have been having babies for thousands of years, which of course is obviously true, but they've also been as bad as our mortality rate is in the United States, it has been exponentially worse historically before modern medical interventions in childbirth. I mean, I think we all recognize that the interventions have gone too far in many cases, and we haven't struck that balance
Yeah,
with preventing complications and still allowing a woman to have a low touch, lower intervention type of birth experience with much more control over what that looks like and how that feels for her. So these women feel they really have no choice but to be outside of a hospital and to the extreme, even without care.
right. And that's the key. It's not like she was receiving care with a midwife or a physician, and then wanting to have a clear set birth plan for when she did deliver in a by a medical professional. This is a movement of no hospitalization, no medical intervention by anyone,
Mm.
and to do it on your own.
Yeah, totally on your own, which is just so incredibly high risk. I mean, it's a great example of the slogan that Julie introduced us to from NASA, that luck is not a strategy, hope is not a plan. It's just so many things can go wrong, and it really is incredible when everything goes right, but it's an enormous risk to take, and I think personally, I think a huge reason why movement has gained some visibility, I don't know how common it is, but some visibility, is there's just really been an eroding of trust in the medical system for the last several years, and people just are fearful and distrustful.
I think COVID was the start of that,
Yeah.
and of course, we have social media now,
Mm,
and we have a lot of TikTok doctors out there,
mm,
doctors in air quotes. I mean, some people with no medical care giving medical advice um, and really getting some of these movements to move along, but it's put a lot of distrust in physicians and nurses. And I was recently teaching, and I had two OBGYNs come up to me. I had just lectured on patient safety, and they said, Suzanne, we're just seeing such an issue with patients not trusting us
mhm,
in the clinical setting. And, we're all about questioning, asking questions about, this, that, or the other, of what the plan is. And please do question care, ask why. And that's the reason why we teach you've got to know the why. But and you're not just forcing medical procedures on patients, you're gaining trust, you're teaching, you're getting informed consent, and you're participating in shared decision making. But that's not the case in every situation. And it has really put healthcare in jeopardy because people are not trusting their providers now.
yeah, and even in the episode, so just to set it up, this patient is brought in by ambulance. They know she's coming in. They get a call ahead of time that this patient is coming in. She comes in by ambulance with severe headache, and immediately they become aware that she is, it's a wild pregnancy. She's planning a free birth, and she's had no prenatal care. And I can see both sides of this, but the interaction, it's very like they're doing nothing to try and build a relationship with this patient. They are
No,
immediately hostile to her, in a very condescending, kind of blaming way. So they're not fostering trust in the medical system.
no,
They're
no. In
kind of
fact,
confirming all of her biases.
exactly, and they're shaming her.
Yes.
I mean, because we see patients that do things all the time that we wouldn't recommend, right? But our approach to that should not be a blame and shame, like this is going to be your fault, and you know, you shouldn't have done this, and look at the harm it's going to be doing to your baby. And I think that pregnant women get that kind of blame and shame a lot because of
Mm.
they're pregnant. I've seen it myself.
Mhm.
I've seen that in the emergency room actually with a patient who came in and had a car wreck and who was drunk. Okay. So the bias that the providers had, knowing, yeah, drinking during pregnancy is not recommended. But the biases that they had against that patient showed up in really inappropriate comments to that patient and inappropriate care. And I witnessed that. It was terrible. But I was kind to her and showed her some grace and said, I'm going to take care of you because she still deserves care by somebody who is not pushing their feelings onto her, right?
Agree, and I mean, I can see how the ED teams would be like, would they see this all the time, and they're like, at one point, the patient is like, "I don't want any care." She basically didn't want anything to be done, and the doc was like, "Well, then why are you here?" Which is a really
Exactly.
good question. Why are you here
Yeah.
if you don't want care? And it puts everybody in a really uncomfortable position because, as providers, as physicians, as nurses, whatever, we are there. I mean, you present to us, that
Right.
implies that you want us to care for you. We
Yeah.
didn't drag you in.
Yeah. And she said, and the patient in the pit said, I just really wanted my headache to go away.
Yeah.
I mean, she wanted something for her headache,
Mm.
because she was in pain.
Mhm. But
So
that's care. That's
I
medical
know.
care.
I know.
Like,
I know.
it's the disconnect. It's very, very interesting how humans can disconnect those 2 parts. Like,
Yeah.
like, I want medical care for this, but I don't want medical care.
Right.
It's very, very interesting. But yeah, so my first comment was, where was this patient's support?
I know.
I mean, because us in OB, pregnant women don't show up by themselves. And if they do by ambulance, somebody's very quickly coming after them. But there wasn't
Mhm.
even any conversation about who's with you, anything. I thought that was a really, like, not wanting prenatal care and not wanting to deliver in a hospital doesn't mean we're on an island with no support. In fact, usually in the opposite, they have a lot of family and friend support for that.
Oh,
I mean, what's your thoughts?
exactly. Yeah. Oh, no, I recognize the same thing, um, that nobody was there
Yeah, nobody's there.
and nobody showed up. So,
Yeah,
yeah.
and they weren't even asking.
No.
Like, when
Right.
she becomes unconscious and codes, I mean, obviously, they're gonna resuscitate her first, but there just was no awareness that there might be somebody else with her,
Yeah.
like the father of this child,
Right.
right?
Yeah, I agree. That was a thing, because she did come in by ambulance, but you're right, and most of the time, somebody's right behind that
Mhm.
ambulance,
Yeah,
but can I tell you what my first thing was?
yeah.
So, before we do that, just spoiler alert, if you haven't watched it and you don't wanna watch it, you might wanna watch it and then come back and
Yeah,
and listen to this podcast,
because 'cause
but,
we're gonna give it all away.
yeah. So the first thing that I noticed is when they got her off the ambulance, and they said she was hypertensive, Dr. Robbie showed that she had pitting
Pitting
edema
edema,
in
yeah.
her extremities, and he goes, "She has severe preeclampsia."
Yeah. And I'm like, actually, edema doesn't have anything to do with the
Yeah,
diagnosis of preeclampsia. It's her headache and her hypertension that give her
exactly.
preeclampsia. Okay, so I just want to say, they didn't have anybody medical advice. They didn't have an OB advising them on this episode because literally everything done to this patient was wrong. Everything. Like, I can't say that anything. It was just so bizarre from an OB perspective. It was like they just they had no medical advisors. So whoever produces HBO, we are happy to serve as your medical advisors and medical consultants to tell you how to do this properly, because
Yep,
this was not proper.
it was not. And so many things, like I said on this show, as I'm watching it, are done right. Like, the visuals are amazing. I don't know
Yeah.
who does their makeup and special effects, but they're great. But the care a lot of times is the recommended care, and
Mm.
I don't know everything about, you know, every
So
kind of aspect of care, but this was not right.
so those of you listening, when you watch the episode, give us a comment on the errors that you saw, because
Yeah,
I'm sure we won't even cover them all. We don't have time to cover them all, but we're going to
I
go
know,
through the highlights.
I know.
The first opportunity, because we're going to use this as an opportunity to, like, explain to you, if this patient is coming into your hospital, what we see as the opportunities to be prepared and improve her care. There's no reason this patient should have coded. Um, First, you knew she was coming to your ED. You got a call that you had a term pregnant patient come into your ED, and nobody communicated with OB. There was never an OB involved in this patient's care, or peds, or there was no one outside of the ED involved in this patient's care until everything was done. And that is not okay. And you could have mobilized your OB resources. There was an L&D nurse. That's it. You could
That's
have
it.
mobilized your OB resources before she ever hit the door.
Well, and she didn't need to stay in the ED.
She shouldn't
She
have even
needed
come
to
to the ED. She should have come straight to triage.
exactly. She should have gone to the OB department,
Correct.
period.
Correct.
Do not
Absolutely should
pass
not have
go.
hit she should not have even hit the ED doors. The
Do
ambulance should have gone
right.
straight up to triage.
Pass go, collect your $200, and you are on the OB unit,
Yeah, so
period,
the
the
fact
end.
this patient was even in the ED is ridiculous.
Exactly. So then they get her in there, and they put her on the fetal monitor.
No, they don't. They put her on CTG.
Yes,
They're going to put on
CTG.
the cardiotocography. I don't even know how to say it.
That's what they said.
Cardiotocography.
Yeah.
No one in OB has ever used those terms, CTG or cardiotocography. Come on.
I know. And they say it, but they're not qualified.
Repeatedly they say it.
Well, first off, that they have a fetal monitor down there.
With no one who knows what they're doing with it.
With nobody who's trained to use it, right?
Mhm.
But they know what a normal heart rate was between 110 and 160.
And all they were caring about was the number of the rate, and assuming that it was the baseline heart rate, they were even know what to do with. They don't know how to even calculate that. But at one point they showed a tracing and it was just a prolonged decel.
Yeah.
Yeah. And it's like, no, actually, there's way so much more to it.
Yeah. The whole fetal monitoring component of the care was disturbing.
Yes.
Because, I mean, she was obviously, she would say, the baseline rate's 128. First off, no, it's not 128, you know. But the other thing was when the fetus would have a prolonged deceleration or bradycardia, they were like, well, it's a little bit better. It's 98.
Yeah, they just completely botched the whole thing. There was no discussion about variability, decelerations, and they put it on before the L&D nurse arrived, which is not okay.
Right.
You can't do monitoring if you don't have someone to interpret it.
Right.
So, yeah, I mean, it's appropriate that they want to monitor the patient immediately, but that's why you need to mobilize the OB team immediately.
Right. And that includes a physician.
Yes. Now, they did treat her hypertension.
Yes.
Or they were trying to treat her hypertension.
With labetalol.
With labetalol. So I'll give them, and with the correct dose.
The correct dose.
So I'll give them that. And then everything they did with eclampsia was completely wrong.
Yeah. Well, before she's eclamptic, they started her on MAG.
Yes.
They gave a 6-gram bolus.
Yes.
And started her on 2 grams an hour.
Mm-hmm.
But it was really quick.
Mm-hmm.
Like within 5 minutes, she'd had her bolus, and then she was on 2 grams an hour, at least 5 minutes. That's max. So that was funny.
Well, and then she starts seizing, and guys, I want you to hear very, very clearly. MAG is the drug of choice for an eclamptic seizure, period, end of sentence. Everything else they did outside of MAG was not correct.
Right.
She should have had more MAG.
More MAG.
More MAG. That's
more
it.
MAG. Yeah, I just keep saying more MAG.
More MAG.
More MAG.
More MAG. That's what they needed. More MAG. In my 26 since I've been out of training, and 33 years of doing obstetrics, including my training, I have not, and I've been in incredibly busy level 4 centers most of my career. Never have I seen a patient have an EEG monitor placed for an eclamptic seizure. Literally never.
Yeah.
Have they needed to be intubated? Yes, many times. Have they needed to be paralyzed in order to intubate? Yes. EEG.
Right. To see if she was still contracting. Well,
EEG interpreted by the ED docs?
Yeah. So go back a little bit.
Yeah.
So first off, eclamptic
it's driving
seizures.
me nuts. Like I'm just coming out of my skin.
I know. Eclamptic seizures are usually self-limiting.
Yes.
Between 5 minutes, 7 minutes max. I mean, that's kind of the general rule of thumb. They're self-limiting. And if you get through those periods with protecting the patient, protecting their airway, giving MAG, more MAG, and then you monitor the fetus afterwards and assess neurologic status.
Yep.
So
they kept trying to monitor that baby during the seizure.
Right. And that's common in OB too. I see that done. It's kind of like know that the fetal heart rate is down.
And if memory serves, I think that was one of the reasons why they wanted to make her stop physically moving, was so they could monitor the baby, which is completely incorrect. You stop monitoring the baby, support the mom, give her MAG, and wait for the seizure to pass.
Right. And in this case, the seizure did not pass.
Well, they didn't even give it enough time.
They didn't give it enough time, yeah.
Before they just started doing polypharmacy, like Keppra and benzos. And I mean, it was I lost track of all the drugs that they gave her.
Yeah. And because she was still seizing after 5 minutes, they paralyzed her, sedated her, paralyzed her, and intubated, which is the correct order that you would want to do. You always sedate first because you can't paralyze before sedation. That would be, whew, can't
Cruel.
even imagine, cruel. And then they intubated. But you see the blade that he was intubating her with?
Yes.
What a whopper. I thought he was going to intubate a cow. See, he pulled that thing out. I was like, oh my word, what is that? It's like a cow blade.
Yeah, I was very, very frustrated by the eclampsia management. I mean,
Yeah.
she just needed more mag. So if you're
She
in
needed
that
more mag.
situation, first of all, the bolus hasn't even finished infusing yet. Okay, so
Right.
you're going to let the bolus infuse. By that time, her seizure will have passed. Okay, and there's nothing to do except wait this out. Okay, and you're not monitoring the baby. Now, if she needs to be intubated, fine, intubate her. But you don't need to do all. You're never giving Keppra for an eclamptic seizure.
Never.
It's not a thing.
But that's a very common med to give for seizure activity.
Yes.
But we don't even know if that's going to even affect the portion of the brain that is causing the eclamptic seizure. I know that Dilantin doesn't, but they mentioned Dilantin too.
They mentioned everything.
Everything. Every med.
Every med. And still nobody's the thing that blew my mind is they're handling all of this, but nobody's going, where's OB? Have you guys called OB? Are they at one point they said like they're in the operating room doing a C-section. Guys, listen, if this is happening down in the ED, somebody's leaving the OR, and I guarantee you a place that size has more than one OB on call who is able to come in. Like there is no world where this is happening in the ED and labor and delivery is not mobilizing every resource they have to get down there.
Right. And
that's not a thing.
This is a teaching hospital.
Yes, there's
Pitt.
plenty of resources.
Right.
One person can leave a C-section.
Right. And there was just an OB L&D nurse that came down.
Yes. And she's not freaking out trying to get people down there.
Right.
I mean, and by the way, you're in a teaching institution, this is happening. Okay, screw the residents. Okay, the residents need to be part of this, but the attendings are the priority.
Right.
They're just like you've got ED attendings handling this situation in the ED. You're looking for OB attendings down there handling this situation in the ED.
Exactly.
With the resident. Okay.
Right.
But all they cared about was getting a resident down there. And that's important. It's not the end. This is critical enough. You have to have an attending.
Right. So now they've got her intubated.
Okay.
And now an EEG monitor on. Showing that she's still having seizures, even with paralyzation and intubation and Keppra times 100 and mag.
The kitchen sink and some tap water and like everything and a bologna sandwich.
Yeah. It was like everything.
Ridiculous.
With a cow tongue blade or cow blade to intubate her.
So, okay. And then for some unknown reason, she codes. So, okay.
She goes into, first she goes into VTAC.
VTAC. Yes, I saw that too. And then VFib.
Yeah. I was like, what?
What? These are the two least likely rhythms that you're going to get when a pregnant woman codes. Okay.
Right.
And if you think of like, why did this woman code? Okay. In this specific scenario, why did this woman code? I don't know.
I don't know. I don't know either.
Because eclampsia doesn't lead to a code unless she doesn't have an airway and you're not able to oxygenate her, which was not the case here.
Right.
She could stroke from severe hypertension, in which case I'm not expecting to see VFib or VTAC. She could have, MI? Like, why? Why would she have it? Why?
Right. I mean, I've seen preeclamptic patients have MIs, but not because she's seizing.
Right.
She wasn't complaining of chest pain before she came in. She was complaining of a headache. I mean,
Yeah.
So none of that went together.
None of it made sense
No.
clinically. Like, why is this happening? This is not a
Right.
thing.
So they
Okay.
they did
They shock her
defib.
twice.
Yeah.
They give her epi.
Yeah.
And
Appropriate.
I'm
but
glad that they were willing to shock her while she's pregnant. It doesn't matter that she's pregnant
Yeah.
or not, but they didn't ever bare the chest.
No.
They had a nipple showing,
Yep.
but they're doing chest compressions, shocking her without baring her chest.
Right.
So not okay there. They were very, very, very hyper fixated on getting the uterus off the vena cava. And I loved to see the fact that they were emphasizing that, but that seemed to be all they cared about. And it just was they even rolled her at one point to get it off the vena cava, which was, I don't know, I found the whole thing to be a little bit like misplaced priorities. That's what I would say. A lot of misplaced priorities in this whole resuscitation effort.
Yeah. She was on her side and they were still doing manual displacement.
Yes. But misplaced priorities in terms of monitoring the baby.
Yeah. Yeah.
Making the seizure go away with other meds that aren't indicated.
Right.
Getting the uterus off the vena cava. But, why aren't we focusing on adequate chest compressions and bearing the chest and, all that? It just like misplaced priorities really just hit me just then.
Yeah. And then comes in Dr. Robbie, and we already have another attending in there.
So now
Still
we have
no
2
OB
ED attendings and still no OB.
Still no OB attending. And
they're talking about the 4-minute rule. So they're
Right.
talking about doing a delivery here. No conversation about a peds or neo team.
Right. He just said, get a warmer. And he called in another ED resident to be responsible for the baby. So I did like he was assigning roles.
Roles, that was good.
Yeah.
Yes.
But to the wrong people.
To the wrong people.
Yeah.
So like, no, that's not actually, no, you are at a teaching institution. You've got 22 people up in that NICU who want to be down in that room right now.
Exactly.
And they need to be setting up that warmer and they want to be in the room. You're planning ahead. So when you call a code blue, okay, so first of all, they anticipated that this was going to be coming, right? And they didn't call a code blue that I saw.
No.
Okay.
And
so
they may or may not in the ED, right? They
yes,
run
but
their
you
own
need
codes.
Resources. So how are you getting your OB and peds team down there?
Right. They weren't, because they were going to do everything themselves. That's
Which
why
is,
they're burned out.
But this is a systems issue in your hospital. If you have a pregnant woman code in the ED, if you don't routinely call codes in your ED, you have to be able to get everybody at the bedside that needs. The AHA says in one call, you have to be able to get all your resources to the bedside. So how are you doing that?
Yeah.
Right?
They were just thinking they were going to be all the resources, right?
Which is not acceptable.
Insane.
That's 2 standards of care in your hospital. Because there are people who do this better in your hospital. So you're practicing 2 standards of care. So that's not good medicine.
Right.
And it's a medical legal risk. And I guarantee you got a pregnant woman coding in your ED, that's a medical legal risk.
Yeah. Yeah.
How are you going to explain the fact that you didn't have the right people? It's one thing to say they refused to come. That's not the case.
Yeah.
It's another to say we didn't think to call them. No, we have no proof they were called. We never, whatever,
Yeah. And it even becomes a legal risk when you say we had no resources.
Yes.
We were busy and we couldn't do that.
Yeah. No.
Yeah. You got to have a pop-off valve.
Yeah. Okay. So then she codes.
Yeah.
Okay. I got to take a breath for this one. Y'all know I have done a lot of resuscitative cesareans. I teach on this. It's one of my areas of interest and passion. And I was on a plane when I was watching this episode. I had to stop.
Did you have your seatbelt on?
Suzanne, I had to turn it off and I had to get up and walk the aisle. I could not. I was dying. I was like, I gotta take some deep breaths here. Like, people are watching this and they think that this is good. And they're like, oh my God, they saved her life. Spoiler alert.
Yeah. Yeah.
And I'm just like, whew, they got lucky. That was so bad.
Yeah. So, So they, just to go back and recreate it, start talking about, we got to get the baby out. We want to start within 4 minutes. Of course, they didn't wait for 4 minutes. I think it ended up being I think they counted it in seconds. So they do a resuscitative cesarean. Okay.
Yes. Okay, wait.
Yeah.
Before they do that, they're gowning.
Yes.
You don't gown for resuscitative C-section. they're prepping the belly, and they pour Betadine on the belly, and then they take their hands and rub it all over the belly.
Yeah. Yeah.
You're not prepping the belly. You're not gowning. You're not draping the patient. You can put gloves on. That's great. But you're not taking any time to do any of those things. There's no way that they would have been able to accomplish all of the things that they were showing in that actual 4-minute time period. We know that in real life. And you gown and glove and drape the patient, and that ain't happening. Okay. And first of all, where are they getting that in the ED? Where are they getting a
Right.
C-section kit in the
Right.
ED for all come on.
Yeah. Yeah. I mean, because we've visited a lot of EDs and they don't know. They usually have a precept kit or they bring it down from OB,
Yes.
but they don't have the,
The OR table, but you don't
No.
need it.
No.
They
no.
had a full instruments, and first of all, they don't have it in the ED.
Right.
No one from OB brought that down, and they don't need it. But you know what killed me? Okay, first of all, he's like 15 blade, like we're calling out a 15 blade. Like, why is that a plot point that we have to talk about the 15 blade? Okay, what'd you think about that incision?
Well, okay. So when I saw them squirting the Betadine, like literally it was like squirting out of a ketchup bottle or something, it was like
it's not a Betadine container for
no,
sure.
it wasn't. No. And it was just like they were up, and I was like, that's a little too high.
Yes, they were well above the umbilicus. They made that incision, and he states it in the episode, xiphoid to symphysis pubis, and then makes the point that they're going to make a low uterine incision to avoid cutting the baby.
Yeah. And
okay, so couple things. First of all, we're not doing a xiphoid to symphysis incision.
It's not a Whipple.
I don't even know what incision they do with the Whipple.
It's
but
like
this is
really
that's
low.
a trauma incision.
Yeah.
Okay. Like, I don't know what kind of incision it is, but it's not OB. It's not resuscitative cesarean. You can do a vertical incision for a resuscitative cesarean. I've done vertical. I've done fan and steel. It doesn't matter. You do whatever's going to get that baby out the fastest. And one of the reasons people talk about in favor of vertical incision is because very often these patients will require re-exploration after, and that will typically be a vertical incision for whatever reason, for a variety of reasons. And so it just avoids the anchor incision. The reality is this is high stress, high stakes environment. You do whatever you feel comfortable with, and it's going to get that baby out the fastest in the safest manner. And if that's fen and steel, I'm never going to second guess you. Okay. But if you're doing vertical, we're going umbilicus to xiphoid. We're not, or umbilicus to symphysis. We're not going xiphoid to symphysis. And then he just cut right through the belly button.
Yeah.
Didn't go around the belly button at all. Like, that's not, and like, come on.
Yeah, it was extra large.
Jesus,
like
it was
the cow tongue blade.
It's ridiculous.
It was like, woo. And then they go, we got the bladder blade.
The bladder blade.
Yeah.
And they're using the bladder blade to retract the sides and not the bladder.
Yeah. So that was.
I was just, the whole thing was ridiculous. Then they described doing a low incision on the uterus to not cut the baby. That sentence doesn't make any sense at all. There's no reason to do anything other than a low transverse incision here. This is a term uterus. It's clearly big enough. Do a low transverse. It's safer. It's quicker. It's less bloody. All the things, right? But on the image, they do a vertical incision on the uterus, and that was clearly AI to me, because the fluid that is bubbling out of the uterus.
Yeah, it's clear.
The fluid bubbling out of the uterus as they're cutting the uterine muscle is ridiculous. I mean, it's just ridiculous.
It was clear fluid. And they said clear fluid.
They were so excited about the clear fluid.
Yeah, which I doubt she would have.
It wasn't have been clear fluid.
No.
There would have been meconium in that fluid for sure.
Yeah. Or some blood.
Yes. Well, okay, so they deliver the baby. They described it as breech. I rewound that thing 3 times. I don't think that baby was breech.
I don't think it was either. I think it was vertex.
It looked vertex to me too, but I was like, why? It doesn't look breech. And I just was confused by that. I don't know why that mattered, because they pulled the kid out head first.
Well, and that they, when they were delivering the baby, he said they were like, "The baby's breech, can I have a little fundal pressure?" And I'm
I
thinking,
missed that.
yeah, I thought, "Why
Why
do you
would you
need
want fundal
fundal
pressure
pressure?
for
You just
breech?
filleted everything open,
Right,
like,
you just filleted everything.
and it's a breech." So
Yeah.
okay, I caught that one.
Then for the non-medical people that might be listening or people who have never been in a C-section, when you break the bag of water, it doesn't just pool like that and cover everything up. It's not like a swimming pool. Like it goes onto the floor. It's not in the belly. You can see everything you need to see. Suction or no suction is just not a thing like that. So that was weird too. It was like
They didn't
they're
have any
swimming
suction,
in a
by the way.
pool. No, they didn't. They definitely did not have suction, but they didn't need it.
No.
Okay, so
The
baby's out and they're still coding mom, and the baby is born, limp and lifeless, and they milk the cord.
Yeah.
I'm surprised they didn't do delayed cord clamping.
Skin to skin.
I mean,
Not that there's anything I mean, that was fine, but, not in that scenario.
no, no, like,
Yeah,
come on. This is not, again,
yeah,
wrong priorities.
right. Baby looked real.
That was one of the best newborn babies I've ever seen in a TV show or a
That
movie.
baby vernix and some blood on it and was blue and lifeless, and the limbs were just kinda flopping off the hands. That was impressive
It was very impressive. That was
until they
very,
start
very lifelike.
yeah,
I
until they
mean,
start to resuscitate it, and
yeah, no. We're gonna
yeah,
get into that.
yeah.
So, but the baby, I thought, like, normally, they have a newborn and shows they're 3 months old,
Yeah.
right? They're teething.
Yeah. Ride a
I
tricycle.
I was
Yeah,
pretty impressed with that. I wonder
I
how
was too.
much of that was AI. Like, did
Yeah,
they do AI on, like, the face or whatever during the resuscitation?
yeah,
I just was really impressed with the special
yeah.
effects with that baby.
That's what I'm saying. The show usually does a really good job on the special effects. The pregnant mom, not so much, but this newborn was great.
To me, it just seemed clear that the people doing the special effects had never, ever seen a cesarean section.
Yeah, yeah. And it had
And
no
there were
consultants like
And they
us.
had no consultant, or at least no consultant that was willing to speak up and say, "This is wrong." Or maybe they were and they just weren't listening to them, but I don't
Yeah.
know. I wouldn't wanna be credited on that if that's the way.
Yeah, yeah. It was the newborn was great though.
Yeah,
So they had a resident, I think she's a second year resident in the ED. She was responsible for the newborn.
totally inappropriate. I don't know the characters because I hadn't watched all the other episodes, but, I mean, they totally botched that resuscitation and got completely lucky. But let's go to the baby in a minute. Let's talk about mom now,
Okay.
okay? So, first of all, she doesn't have ROSC. She doesn't have a
No.
pulse, and they're talking about bleeding, and they're giving her blood products. Well, I didn't see any estimate of blood loss. I didn't hear any discussion about vital signs. I'm not saying it was wrong to transfuse her. I just felt like when they said she needs 2 more units, I was like, "What does she need 2 units for? Like, what are we
I know.
talking about?" And, she's not gonna be bleeding from the uterus.
Right. She had HELP syndrome too, they said. They got
Mhm.
her labs back and her
Right.
platelets were 50,000 and her liver enzymes were sky high.
Yes.
So all I could think of was she's 36 weeks
Mhm.
when this appears. So
Mhm.
women who have later onset of preeclampsia with severe features,
Don't
I mean, they
typically
can
have
have
HELLPS.
HELP syndrome, but they usually don't, right? Those patients usually have um, earlier in gestation diagnoses, but I've seen it at
Yeah,
term, obviously. But of course, she was going to have HELP syndrome, so she
of
has HELP
course.
syndrome on top
Yeah,
of
I forgot
being
about that,
eclamptic.
but that wouldn't make her bleed because
No,
she
not
doesn't have perfusion to the uterus while
right,
she's in arrest, so
right,
that was a fallacy too.
right.
And I didn't hear any conversation or see any evidence that they were trying to close the uterine incision.
No,
They were very impressed with their placenta delivery, though.
that
That was a
placenta was
that was a good placenta.
well, but
It was
it
a
was
little too
little.
stiff.
It was little too. It seemed to me. I thought it was
Wasn't
small.
thick enough. It was a little too pancakey, and it was too stiff. Like a
Okay.
placenta, if you hold the placenta the way, it's gonna flop like it's not gonna hold flat. So it was a
Right.
little too stiff, but I thought it was pretty decent for a placenta.
Looked good.
But nobody's inspecting the placenta the way they did. Like, nobody in
Mm,
OB, they're just like, "Get this thing out of here. My hand's in the uterus." That's how I'll know if there's anything left behind.
but the ED docs inspected it.
That's what I'm getting at. Like, they don't understand. Like,
Yeah, yeah,
totally missed priorities.
yeah. But, yeah, I thought the placenta looked pretty good except for it was a little small, so she could have had hypertension for some time.
But that was not a growth restricted baby.
No, it wasn't.
And the placenta is a percentage of the baby's weight, so
Yeah.
that didn't really match. But I'll give him a break on that one.
Yeah, we're not gonna be too hypercritical on that one, because I mean, after all, she's still coding. And then
She's
she went into PEA.
now PEA is much more realistic.
Exactly.
Okay, that's much more realistic of how a pregnant woman is going to code.
Exactly. And so I was like, well, finally we got the right rhythm.
Yeah. So, and then they get her back. Of course, they saved her life. Hoo-ha, hooray. And then, now let's go to the baby. Okay.
Oh, Lord. You know me. I've always said this. Much rather resuscitate an adult than a newborn. Because I've always worked in institutions that have these very, very large NICUs. They're the experts, you
Yeah.
know. I would do NRP, but I
Yeah.
still suck.
Well, I've never been in charge of a newborn resuscitation. I mean, that's not my role.
Yeah.
But I've witnessed thousands of newborn resuscitations, and I'm married to a neonatologist. So let's talk about this neonatal resuscitation. I think, so first of all, to me, this is another phenomenal example of misplaced priorities. I have never seen a team so obsessed with an APGAR score.
Yeah.
Who cares about the APGAR score?
Yeah. Well, I thought they were more obsessed about the pulse oximetry
Yes.
than actually trying to oxygenate.
They were watching this baby die, is what they were
Yeah.
doing,
Yeah.
giving it a tincture of time. One of the residents said that, tincture of time.
Blow
Well,
by, which actually looked like she was blowing into something.
No, that was suction. Okay. So
I was like,
that
what is
one
she
got me
doing?
too. So first of all, they should have been stimulating the crap out of that baby, and they should be intubating that baby. You need to oxygenate a baby. You're going to do positive pressure, and then you're going to do intubation if you can't get the response that you need. It's not blow by.
Right.
And your meds go into the ET tube, not into the bone.
Yeah.
Intraosseous.
I know they did. They said we're going to have to stand by for an IO placement, and so somebody grabbed a drill and went vroom, vroom, and revved it up a little bit. You know, it was a little baby drill too, and I was like,
That's
no.
ridiculous. It's ridiculous.
Yeah.
Okay, that's ridiculous. You're
Yeah.
giving meds through the ET tube.
Yeah.
You're not giving meds in the IO. I mean,
On a
IO is like
newborn.
when you can't, that's like a last ditch, and they haven't even done the first ditch.
Right.
They haven't even done
Exactly.
basic resuscitation.
Exactly. Right.
But so that wasn't wrong to suction the baby, but that was not hooked up to wall suction or
No.
any kind of suction. She was doing mouth to tube suction. That's what that was.
A
That's
dilly.
like extremely old practice. And
I know.
like she's sucking the contents into her mouth.
Yeah. Or trying
not to, but good luck.
It was like a dilly.
Yeah.
And
Mouth delay.
And, you know, we've been into hospitals where they were still doing that. And I'm like,
It's not okay. I mean, this is such old practice.
Why are you
Yeah.
using a dilly?
Why?
Good gosh. Just
Yeah.
get a suction catheter.
Yeah, no.
Yeah.
Just suction.
Yeah. But
Wall suction. But that's what that was. So they're knowing to do that, yet they're not doing basic drying and stimulating. They're not doing positive pressure ventilation. They're obsessed over the pulse ox instead of the condition of the baby as it appears.
right.
It's very bizarre. And no baby is going to just magically start crying after laying there for 5 minutes.
Yeah.
And now they're all, oh my God, we've done a great job because the APGAR is now 8. You didn't do anything. This was Darwin at work right here.
Yeah. Yeah, it was pretty bad, and like I said, I am not an NRP
Yeah.
expert at all, but we weren't even doing BLS
Nothing. They were
on the
literally
baby.
observing whether a baby could live or die on its own.
Yeah, it reminded me of this video that Ina May Gaskin showed me one time about how an elephant births. She literally showed me this video of an elephant birthing,
Mhm.
and the baby basically plops out, right?
Mhm.
And the mom, to stimulate the baby, licks it,
Mhm.
and the baby's just laying there, and you're just like, oxygenate, like, breathe, breathe. You know, I mean, we would never sit and just, if it's going to breathe,
Observe.
it's going
Yeah.
to breathe, and I'm
Yeah.
going to lick on it.
Yeah.
And finally, after 5 minutes, this elephant, starts to move and breathe and gets up pretty quickly. But it was shocking because it reminded me of
Shocking.
the elephant licking its baby.
They gotta do something. Like, you start with basic drying and stimulating, and
Right.
then and yes, you're gonna do your APGAR score, and so I don't want people to misinterpret. Yes, APGAR scores have a role, but you're not guiding your resuscitation on the APGAR score number. Your resuscitation is guided by heart rate and oxygenation and tone and all the things that, like, the components of it, but you're not going, "It's an APGAR of 5, let's," or it's just
Continue.
that's
We're
just is
doing
not
good.
it's not a thing, and
Right. And
misplaced priorities.
yeah, well, the first APGAR was 5. And
The
and
first
they
APGAR was 1.
well, I know. The APGAR was
Was
1.
1, assuming the
And
baby had a heart rate.
because the baby wasn't breathing, the baby was limp, lifeless, blue,
It was a
no
1.
grimace. Finally, after, a couple of minutes, she said, "We have a grimace. That's good. We're going the right direction." And I'm like, "Baby's still blue."
And they
And she's like,
blocked. Go
"Right."
ahead, sorry.
She said the pulse ox was 43. She said, "I've never seen one that low." And I'm like, "And you're not giving it any oxygen. You're
Right, and then
not
they're like, "Should we
bagging the
intubate?"
baby."
He's like, "Tincture of time."
I know. I think that was an attending
Well, it was bad, whatever it was. There
or
was
a
no
chief
tincture.
resident.
It was bad. It just
Yeah.
shows you, like, get your neo team there. Get your peds team
Yeah.
there. Oh my
Yeah.
god.
And the OB nurse, I mean, she would have known more than that, but I think she was still doing uterine displacement or
Well, she was
monitoring.
bleeding, and they're just packing with laps,
Yeah.
just
Yeah.
packing away. I'm like,
Well, she's got an incision from her xiphoid onto her
it's gonna take a
symphysis.
few more laps than that to
It
pack
was
that out.
gaping.
How about you close the incision?
Yeah. It was ginormous.
Close the incision, close the uterus. That's
Yeah.
step 1 to controlling bleeding.
Yeah. They gave Pitocin 10
10.
IV. So
Oh, I missed that. Did they really?
yeah, they said IV. Yeah. So, surprised they didn't start an intraosseous on her too.
Right. Oh my god.
Yeah,
Okay,
it
well, I
was
wonder if I guess the season finale, we don't know. I'm like, what's gonna happen postpartum? Is she gonna get press and get a hysterectomy? Like, what's gonna
in
happen,
the ED.
Yeah. And then the hapless OB, I'm assuming resident, comes in and goes, "Did I miss anything?"
Yeah, yeah. Yeah, she got ROSC, and so Dr. Robbie left the room,
Mhm.
and,
My work here is done.
my work here's done, and, now that I have filleted her open from her xiphoid down to her symphysis, gosh, you know what? That how many inches? That would be like a 1.5 foot incision, don't you think? From
It's
over a pregnant
insane. Like, that's an
belly.
oncology like, this is ridiculous.
Yeah, it's like a whipple. But, anyway, it's it was
Bad.
interesting, but she
Mm.
got ROSC, and they were both gonna go to the unit then. And then I think that the OB finally walked in at the
Yeah.
end and
The OB
said that,
walked in, is like, "What did I miss?
"What did I miss?"
Or
And
did
he
I miss
said,
anything or what?"
"I was in the OR with a twin septic patient." That's what he said.
Oh my god.
Yeah. So I was thinking, what was her sepsis from? Can we talk about that
Yeah,
one?
just talk about that one.
So I think that we should be producers on any episode or,
They need
consultants
they need a
for
consultant.
we are your high risk people in the United States.
We can
You
tell you how to
need
make it look realistic and credible.
right. So the pit,
Call us.
call us,
I'm now a fan.
She promises to watch your show if you call her to be a consultant, and we will help you. This has been my goal in life, by the way, for a long, long time. I'd had 2 goals in life.
Mhm.
One was to work as a hobby.
To work as a hobby, what do you mean?
That's all
So
I
the
want.
work is your hobby?
Yeah, yeah.
Oh, I get
To
it,
work
okay.
as a hobby,
Okay.
that my work is a hobby, and then second, was to be a consultant for TV shows
Oh,
or
okay.
movies, so
Well, this is
maybe
step
I
1
could
maybe,
fulfill.
huh?
Yeah.
Maybe.
Well, now I've got 2 different hobbies the older I get, so I won't tell you what those are, but
They're clean.
yeah, no, yeah, it's all physical characteristics at this point. But, yeah, so it was a I don't know, it's a great show, I think
I can
for
see why people love it.
yeah, I mean, I love the emotional part of it and about how healthcare providers really absorb a lot
Yes.
of the trauma that they see in their real lives
Mm.
and how we deal with that, seeing so much trauma and death, or adverse situations or,
Mhm.
you know, even just access to care and things that could be different if we had more of a say in how that worked, right? Um, but it was, and then also about how you feel good though when something goes right, but how you take the other if it doesn't go right. And sometimes you can give your best care and still things don't go right, right?
Really high
So,
highs and really low lows.
yeah. And so I think that they're really doing a good job of that and recognizing from a nursing perspective, I love, the charge nurse and the nurses. And,
They're badasses, clearly.
man, they are badasses, and they're smart, and they know what they're doing, and but they respect that on this show, and they really even when they do interviews, they talk about how, um, these healthcare providers, how hard they work and how they need to have, more kudos to them for what they do because these actors are like, "Holy cow, I couldn't do this," on an everyday basis.
Um, are there other OB patients in the ED we need to talk about on the pit?
No, that's the only
Okay,
one
it's the
they've
first one,
had.
huh?
Yeah.
By the way, this started as a wild pregnancy free birth situation. Preeclampsia can't be predicted, and we didn't get any information that would suggest that she would have been at high risk for it occurring. It might have been diagnosed earlier,
Yeah.
and for sure, but this can happen whether you get prenatal care or not. That said, please get prenatal care. There are
Right.
so many things that improve outcomes, like prenatal care is valuable. Medical care is valuable, but I think we as a medical community have to take responsibility for how we can make it better, um, and more accessible and have people trust us more. So, well, that was
Yeah,
fun.
it's a that and the trust
Mm,
issue, I think that we've got to continue to address. I will say that I've seen a lot of chatter online about this episode, and it was traumatizing for patients who have had a traumatic birth,
mm.
re-traumatizing
Yes,
them
I could
to
totally imagine that.
yeah, that. And the other thing that I want to remind people, this is Preeclampsia Awareness Month. And the Preeclampsia Foundation has some great resources that are free online, and to reach out to them, and to stay updated on preeclampsia and how to care for patients. And then lastly, have your system in place for your OB patients in the adult ED.
Mhm,
OB, that physicians, that involves you
mhm.
and not just an L&D nurse or going down. But we gotta work together better
Yeah.
and,
Assume
and
this is gonna happen in your hospital. How are you gonna deal
assume
with it?
it. Yeah, no matter
Yep,
what your level
yep,
of maternal care is, this
yep.
patient can come to you any day.
All right. Well, everybody, thanks for listening. That was a fun one to
Yeah.
do. You can find us at clinicalconceptsinob.com, and you can check out the academy with all of our high risk and critical care OB education programs. Follow us on all of our socials. We're on Instagram, LinkedIn, Facebook, And we look forward to interacting with you guys again. Thanks.
Bye.